Welcome to Journal Club, new insights into transthyretin amyloid cardiomyopathy, ATTR-CM, diagnosis and emerging therapies. In this episode, the clock is ticking on ATTR-CM. Dr. Kevin Alexander and Dr. Akshay Desai discuss the clinical manifestations and how to make the correct diagnosis of this disease. Journal Club is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Bridge Biopharma, Incorporated. Information about the faculty and disclosures can be found at journalclubpodcasts.com/ATTR-CM1. You can use this link to receive your credit and evaluate this program. And for your reference, a PDF of the diagnostic algorithm for cardiac amyloidosis is also available for download. The URL can also be accessed in the episode notes. Dr. Alexander is an assistant professor of medicine at Stanford University School of Medicine and a member of the Stanford Amyloid Center and Stanford Cardiovascular Institute in California. Dr. Desai is an associate professor of medicine at Harvard Medical School and medical director of the cardiomyopathy and heart failure program in the advanced heart disease section of the cardiovascular division at Brigham and Women's Hospital in Boston. I am your host, Candace Hoffman. Dr. Alexander will begin our discussion.
Well, Akshay, thank you for joining me today to kick off our discussions on the need for early diagnosis of ATTR-CM. Let's start by leveraging clinical clues from patients' history, physical, and imaging findings that may be required when there's a suspicion of ATTR. And then we'll discuss a systematic approach to correctly diagnose the disease. So perhaps we could start off by you giving us an overview of what is amyloidosis and what are the forms that commonly affect the heart.
Yeah, so Kevin, first of all, thanks for joining me today in this conversation. I think it's important for everyone to realize that cardiac amyloidosis is really a broad term used to refer to a number of different protein folding disorders that are related to overproduction of amyloid proteins, either produced in the liver or in the bone marrow, that then disaggregate and create fibrils within various tissues within the body, of which the heart is one. So I think we generally categorize amyloidosis into two large clinical forms, although there are many other forms available. One is AL amyloidosis, in which there's a plasma cell dyscrasia, a monoclonal expansion of plasma cells within the bone marrow that overproduce immunoglobulin light chains that are released into the circulation, misfold, and then deposit in tissues. The other variant is the variant of ATTR amyloidosis, which is misfolding of liver-derived precursors of transthyretin, which is also called prealbumin. And this form of amyloidosis, ATTR cardiac amyloidosis, comes in really two forms. One is a hereditary form that's often associated with mutant forms of transthyretin that often has a dominant polyneuropathy association, but can also affect the heart. And then the other form is a wild type transthyretin protein that's overproduced in the liver. That's typically a form of amyloidosis we see in older populations and is an aging-related phenomenon. But both forms of ATTR amyloidosis kind of have similar clinical presentations with some minor variations. But so the most important differentiation, I think, is between those patients with a bone marrow disorder and those patients with ATTR cardiac amyloidosis. So I think, broadly speaking, that's those are the entities we're trying to differentiate. But I know you spend a lot of time thinking about these patients. Any additional thoughts there from your perspective?
Yeah, actually, I think you covered it very nicely. The vast majority of cardiac amyloid disease really boils down to light chain, or the more common ATTR amyloidosis. And you outlined very nicely the two subtypes of ATTR-CM. So along those lines, I mean, I think that we've got an increasing understanding of the prevalence of these diseases over the last several years. Actually, could you comment a little bit about how common or not are these cardiac amyloid diseases from AL amyloid to as well as the ATTR subtypes?
I think we're starting to realize, Kevin, that this is an increasingly common problem. But I think it varies depending on the type of amyloid we're talking about. If you talk about AL amyloidosis or light chain amyloidosis, in which we're talking about patients who have an underlying plasma cell dyscrasia, that disorder is relatively rare. That's about 3,000 new cases in the United States each year. But the other forms of amyloidosis, the PTR variant amyloid cases, are actually are increasingly common as we look for them. And I think we're realizing is that because we didn't have a lot of effective therapies, we often didn't look that deliberately for ATTR amyloidosis. And now, as we're looking more aggressively for this disease, we're finding it. Some of the series suggest that if you look at garden variety heart failure with preserved ejection fraction, which is a common problem in the elderly, particularly adults over 60, as much as 12 to 15% of those patients with heart failure and preserved ejection fraction, if systematically evaluated, particularly the men, older men, may have underlying cardiac amyloidosis. If we look at much older populations, octogenarians at autopsy, the prevalence rates might be even higher, in the range of 15 to 20%. And then if you look at subsets of patients that are also known to concentrate those with amyloidosis, like those with low flow, low gradient aortic stenosis, it's again about 8 to 10% of those patients. So I think that we're increasingly realizing that ATTR amyloidosis is actually a pretty common problem. Now, the hereditary variant of ATTR is probably less common than the wild type variant. And I think you've done a lot of work in this space and probably could comment a little more than I can on the prevalence of the inherited phenotypes. But I think what we often see in clinical practice are the age-related wild-type ATTR cardiac amyloid.
Yeah, I completely agree. Wild-type ATTR amyloidosis by far dwarfs either hereditary or AL amyloidosis in terms of the overall prevalence. In the subpopulations that you mentioned, such as low flow, low gradient aortic stenosis, people with bilateral carpal tunnel syndrome, or even the overall HFpEF population, there's a significant proportion of underlying wild-type ATTR patients in those groups. You touched on hereditary ATTR, which comprises of a number of different variants that can confer disease. And we know that those variants have varying levels of prevalence in racial ethnic populations. In the United States, the most common variant is the V122I or the V142I variant, depending on the nomenclature you're using. And that's carried by 3 to 4% of African Americans or people of African descent. And so that means there's well over 1 million carriers in the US alone. And this variant confers a disproportionate burden of heart failure and other comorbidities in this population. There's been nice work that's come out for various groups, including a recent JAMA article that really highlights this added burden of this variant in that population. And so I think taken all together, like you said early on, ATTR-CM is much more common than those previously appreciated and confers much more heart failure morbidity and mortality than was previously appreciated.
Yeah, I think, Kevin, you've done a lot of work to highlight that even the lack of diagnosis of amyloid is actually a pretty important problem, right? Because if we fail to diagnose it, then the disease does tend to progress and is associated with a high degree and a high burden of morbidity and mortality. And I think that it sort of highlights that there really needs to be a high index of suspicion, particularly in those populations where we know amyloid is particularly prevalent that we've discussed: HFpEF, low flow, low gradient aortic stenosis, heart failure in association with carpal tunnel syndrome or peripheral neuropathy. I think those patients really we want to suspect amyloid and look for it, because if we look for it, we might find it, and that might substantially alter our approach to therapy.
I completely agree. And one study that I worked with Sharmila Dorbal, your colleague at Brigham Women's Hospital, on, we looked at death certificate information to understand reported amyloidosis mortality. One of the key takeaways from that paper was how heterogeneous the reported amyloidosis rate was across the country. And the pattern that emerged was that higher reported amyloidosis mortality clustered around established amyloidosis centers. So I think driving home the point that there needs to be a high clinical index of suspicion and awareness in order to make this diagnosis, because I think, as you outlined, there are a lot of comorbid conditions that patients get diagnosed with, and people can anchor on those as the leading diagnosis, but they have underlying or concomitant amyloid that's driving their symptomatology. And so I think that that's one of the important areas that, hopefully going forward, we'll continue to make improvements in terms of raising that awareness and becoming more standardized in how we screen for these patients in those subpopulations that you've highlighted.
Yeah, I think the only other point I might make is just in terms of the epidemiology is that, you mentioned the importance of the racial and ethnic variation in the presentation, and particularly the hereditary amyloid variants. I think there's also a little bit of a gender variation or sex variation in the presentation. AL disease is relatively similar prevalence in men and women, whereas ATTR amyloid seems to have a higher prevalence in men, particularly older men. So, when we're looking for those patients who might be high likelihood of having amyloid, I think it's particularly the older male patients, particularly the older male African American patients with HFpEF, where we really want to be sure we're not missing it, although it's certainly seen in both sexes.
Absolutely. So in your clinical practice, actually, maybe kind of walk us through what are some of the clinical signs and symptoms that we should think about, and then we'll kind of go into some of the imaging and diagnostic testing that's suggestive of cardiac amyloid disease.
Yeah, so I think that we've talked about that importance of knowing in whom to look for amyloid, and I think there are a few clinical syndromes I think that are important to think about, and then a number of clinical findings or historical findings, and then we can talk about imaging findings or laboratory findings as well. I think from a general clinical perspective, if you have a patient who has heart failure with preserved ejection fraction, I think you're obliged, man or woman, to think about the possibility of amyloidosis. And that possibility is amplified in the presence of other suggestive features like bilateral carpal tunnel syndrome, a history of biceps tendon rupture, because we know that particularly ATTR amyloid concentrates in tendinous regions and may predispose to tendinous rupture and other tendinopathies. Patients with spinal stenosis and heart failure with preserved ejection fraction might be another category. Patients who have aortic valve disease but low flow, low gradient aortic stenosis, we've mentioned. Patients who have atypical heart failure epidemiology, that is, you have a HFpEF patient who's young and lean, doesn't have a history of hypertension. That's a patient where you should be thinking about amyloid. And I think if you have HFpEF in the absence of usual triggers, there's no hypertension, there's no obesity, there's no diabetes. That's another patient population we should say, why does this patient have HFpEF? Could they have amyloid? And I think the last overlap that we should be aware of is that if you have hypertrophic cardiomyopathy, it's often diagnosed earlier in life. So if you have a 60 or 70-year-old and you're making a first diagnosis of HCM because you see thick walls, remember that there are other things that might make the wall thick, including infiltrative diseases like amyloid. So I think those are populations where I really think we should look hard. And then we want to think about historical clues. Is this, we've talked a little bit about the things that the fellow travelers of particularly ATTR amyloid, is there evidence of carpal tunnel? Is there evidence of spinal stenosis? Is there evidence of orthostatic hypotension? Is there evidence of other dysautonomia or early satiety? Is there evidence of postural hypotension? I think also looking for AL disease, is there evidence of periorbital bruising or a macroglossia, some other clinical features that might suggest large shoulder pads that might suggest significant amyloid deposition in the soft tissues. And I think in those patients who have kind of the clinical features that might suggest amyloid in the clinical context, those are the patients where we really want to dive in and systematically look carefully at the echo and then consider additional multimodality imaging. I don't know if you have other thoughts about the clinical approach.
I think you covered it very well in terms of how broad we should be thinking about some of these manifestations, particularly the early manifestations, which often are extracardiac. And then kind of going back to raising awareness and diagnosis of this disease, I think it highlights the fact that there are many practitioners that will see these patients oftentimes before an advanced heart failure cardiologist will. So I think from an epidemiologic standpoint, we have to continue to figure out how to tailor education and screening to a diverse range of physicians, whether they're primary care physicians or orthopedic surgeons, other internal medicine specialists. So I think it's a disease that won't have a one size fits all approach to identifying these patients. And so hopefully there's groups out there, with expertise in implementation science that can help us, tackle this issue.
Yeah, and I think once we have sort of identified the suspicion for amyloid, then I think the diagnostic workup typically begins in most places with an echocardiogram. I think you see the echocardiogram, and there may be very typical features that you could see. Certainly, thick walls. If there's a lot of amyloid deposition, although not all amyloid patients have very significant wall thickening, we tend to see make a lot of the echo texture of the myocardium on a but you have to be a little careful about the gain on the echocardiogram. If you overgain the images, then you'll see a lot of sparkling that might mislead you. But in general, at normal settings, if you see a lot of starry sky appearance within the echocardiographic appearance of the myocardium, that might suggest amyloid. It's not a very specific sign. I think if you see very small ventricles that are thick with thick walls and very large atrium, that's sort of the pattern of infiltrative cardiomyopathy in general and should suggest amyloid. And then I think the Doppler parameters in amyloid can be very suspicious if they're very low myocardial relaxation velocities in systole and diastole. That can sometimes suggest that there's muscle infiltration that is compromising cardiac function and prolonging relaxation time. So I look at the general images, the wall thickness, the Doppler features, and then I think increasingly we're using strain imaging because there is this observation that deformation imaging, looking at longitudinal strain or global strain, that there is in many patients with particularly ATTR amyloid that there's preserved apical strain and more effect on contractility or motion at the base, such that there is a regional difference in the strain on echocardiography that might suggest amyloid. So those are some of the echocardiographic features that I look for, and that really push me to make more of a dive into additional imaging for diagnosis.
Great. And, I think that as people have an increasing suspicion for amyloid, many people will get an ECG, an echocardiogram, and may see some of those features that you've described. And as a next step, sometimes people will get a cardiac MRI or a technetium pyrophosphate scan. Can you kind of unravel that a little bit about what your approach is to these imaging modalities and maybe when you'd use one or the other and kind of how they all fit into the overall diagnostic algorithm?
Yeah, so I think that one thing I didn't mention was electrocardiography, which is sometimes helpful. I think there is sometimes a little over reliance on this notion that all amyloid patients have low ECG voltage. I think we've learned that that's not always the case, but if there is a big discrepancy between the voltage on the ECG and the LV mass seen by echo, then that might be a circumstance where you'd say, gosh, very low voltage for the amount of hypertrophy that suggests amyloid. With regard to other imaging modalities, I think that echocardiography is not always diagnostic, and sometimes the images by echo are limited, particularly for 2D characterization. And in those circumstances, I think we have utilized MRI to give us more granularity on myocardial function, give us a little more evidence of whether there are features suggesting infiltration. And on MRI, we can see a number of patterns that are highly suggestive of amyloid infiltration, including suboptimal myocardial nulling and some patterns of late gadolinium enhancement that may suggest amyloid deposition within the myocardium. So I think where there's suspicion, but the echocardiogram is not definitive, then an MRI may add some value. But I think it's important to realize that it's very hard to definitively make a diagnosis of amyloid by either echocardiography or by MRI. And so in general, we start with echo and MR imaging, which have complementary features. And if the diagnosis is suggestive, then we usually move to our laboratory testing and confirmatory imaging. And that's where I think serum testing for free light chains, because we always, when we see amyloid in the heart, want to first exclude a monoclonal gammopathy or monoclonal protein that's arising from the bone marrow. And to do that, typically we arrange serum measurement of free kappa and lambda light chains, as well as serum and urine immunofixation electrophoresis, not serum protein electrophoresis, which is less sensitive, but immunofixation electrophoresis. And that is our comprehensive test to see whether there's a monoclonal spike that can be detected of light chains in the serum. And then while we're looking for the light chains, we're looking to see whether there is more specific imaging we can do to suggest amyloid. And that might be a technetium pyrophosphate scan. And technetium pyrophosphate scan is a is scintigraphy that was historically done for bone imaging, but we've recognized that patients with ATTR variant amyloid and a lesser number of patients with AL amyloid take up the tracer within the heart. And if there's a substantial amount of cardiac uptake of the technetium tracer, then we can suspect that that patient has amyloid infiltration in the heart. It's fairly specific. I think the problem with technetium imaging is that it's not specific for a particular type of amyloid. More commonly, patients with a positive technetium pyrophosphate scan have ATTR disease, but a small proportion may have AL disease. So it's really the combination of the technetium scan and the monoclonal assessment for a monoclonal protein that really helps you make the certain diagnosis of ATTR cardiac amyloidosis.
Yeah, I think so. Yeah, just to add on that in terms of our usage of technetium-based scans for diagnosing amyloid. So, of utmost importance, as you've outlined, Akshay, is really to rule out the presence of a monoclonal gammopathy. Because if you have a positive scintigraphy scan in the presence of monoclonal gammopathy, there's still that chance that it's one of those less common patients that have AL amyloid disease, and certainly has a lot of prognostic and treatment implications to get an accurate and timely diagnosis. And so if someone does have an abnormal monoclonal profile, then really the gold standard, which it was historically before technetium scans, would be to perform a biopsy. Where you biopsy, I think, depends on your practice setting, but often at our center, I know yours as well, would pursue an endomyocardial biopsy to confirm the diagnosis and get a definitive subtyping of amyloid disease. I think there's some other caveats in terms of false positives and false negatives for scintigraphy that we should all kind of bear in mind in terms of not only AL amyloid, but if you're only using planar images, there's a risk that you can get a false positive due to blood pool effect, and you could rule that out if you had the accompanying SPECT images. And there's other types of injuries or exposures that can sometimes lead to false positive technetium scans, such as a recent MI, rib fracture, hydroxychloroquine toxicity, and other amyloid diseases. And as we use these scans more widely, we're recognizing that their diagnostic accuracy is not uniform across ATTR. There are certain TTR variants that sometimes can have false negatives, so something to keep in mind. If you have a high clinical suspicion but have a negative technetium scan, really should think about doing an endomyocardial biopsy for a definitive diagnosis. Make sure that you're not dealing with a scenario where there's a false positive scan.
Yeah, I think it's really critical that I think as we've moved to an era where we are more and more commonly making a non-invasive diagnosis of amyloidosis based on the pairing of laboratory assessment for a monoclonal protein and technetium pyrophosphate scintigraphy with or without an MRI. I think that we need to be very careful about some of those false positives and false negatives. And it's not that uncommon for us to see a monoclonal gammopathy of unknown significance in the presence of TTR amyloid. And so I think it's not rare that we occasionally do need to confirm the diagnosis with biopsy. And my preference in clinical practice is really to biopsy the involved organ. I think the surrogate site is easier to access, abdominal fat pad or rectal fat pad biopsies, but sometimes we can be misled or falsely reassured by those tests. And so I think if you get a negative biopsy, but the clinical suspicion remains high, then you really want to go after the involved organ or the area that raised your suspicion in the first place. So I think beware of that variable sensitivity of the fat pad biopsy and realize that the morbidity associated with endomyocardial biopsy, or if appropriate, renal biopsy is really not extremely high in the right circumstances. And so I think it's worth pursuing for confirmation if there's ambiguity. I think, as we've outlined it, there's a high clinical suspicion that's suggested by history and exam features. We're evaluating in those patients who have suggestive disease with echo or MRI. If the data suggests that there may be amyloid, then looking for a monoclonal protein. If there's a monoclonal protein present, we go down the AL amyloid pathway and pursue additional tissue testing to see that if there's tissue deposition of amyloid, and likely bone marrow biopsy to confirm the presence of a monoclonal protein and a plasma cell dyscrasia. Whereas if there's no evidence of monoclonal protein, we're going down the pathway of technetium pyrophosphate scanning. A very positive scan with grade 2 or 3 uptake would suggest cardiac ATTR cardiac amyloid. And if there's no uptake or a very low probability scan, then it's probably not cardiac amyloid. You got no monoclonal protein, a negative pyrophosphate scan. It's got a high degree of negative predictive value. So I think you're unlikely to miss it unless you have very early disease or one of those unusual variants you mentioned. So I think those are sort of the pearls, if you will, for making sure that you systematically approach the evaluation and diagnosis of cardiac amyloid from my perspective.
Great. Yeah, thanks, Akshay. I mean, and I think that couldn't say it better myself. And I like how you outlined the sequential nature for diagnosing this condition. And I think it's important to remember some of those pearls and pitfalls that you outlined when thinking about patients with suspected amyloid. And they collectively, as a medical community, will increasingly get more expertise with this, and that will hopefully lead to earlier diagnosis and access and initiation of effective therapies. And on that note, I look forward to our next podcast where we delve into more detail about the emerging therapies for ATTR-CM, as well as where research has gone in terms of understanding response to treatment or the other side of the coin, disease progression. And so I think we'll have a great opportunity to discuss those things in more depth.
Yeah, it's an exciting time, Kevin, and I've really enjoyed this conversation. And I think the key message for our audience is that we have effective therapies for this disease, as we'll talk about, and this only underscores the importance of early diagnosis, because even though we have therapies to slow disease progression, we don't yet have very many curative therapies for this disease. And so the earlier we make the diagnosis, the less the likelihood of progression to the end stage of disease, where we really have very limited options for treatment. So I think a critically important diagnosis to make, and it starts with a high index of suspicion. So thanks for the conversation and the opportunity.
Remember to receive your credit and evaluate this program. Please visit journalclubpodcast.com/ATTR-CM1. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming service, or download our Morning Commute app for all of our Journal Club and Morning Commute podcasts. Thank you for joining us today.